Thank you all for coming today and spending your Saturday with us. I always think that you guys must be tired of hearing what I have to say over and over again, and yet you still show up, and so many familiar faces. Thank you for being here, and happy International Women's Day. I could not imagine a woman worth celebrating more than Jenny. You have done remarkable things that have had international impacts for women, patients everywhere. And I think I speak for everyone when I thank you, your team, Cindy, but all the women out there that are doing your darndest to fight this, to find that cure, to support your caregiver, and to all the men behind the women who are making their dreams come true. Thank you for that too. All right, I have been given the topic, the very easy topic of CAR T cells, which is exciting, wonderful, stressful, anxiety-producing. I hope I can try and clarify a little bit of what has happened, what is coming, and kind of help you kind of take that step towards CAR T if this is in your future. So without further ado, my disclosures are here. I love these calendars or kind of schedules just to kind of help us understand, how did we get here? You know, CAR T has been this thing that has been looming in the sky behind us for all these years. And finally, the word is out. I think many patients walk in the door and say, I want CAR T. And I say, well, let's talk about it. And the more we talk about it, the more history unfolds to say, how did we get here? Well, the initial kind of thought of all of this really dates back more than a decade at this point, where 2013, we finally are identifying that we can find something on the myeloma cell that is worth attacking, worth killing, and really began the beginning of this evolution of using your immune system to fight your cancer. And so 2014 was the first time where we saw these clinical trials start at the NCI, where over the years now, and this is how clinical trials go. Thank you to all of you who have participated in them, because you are getting access to cutting edge therapy, but you are paving the way for patients behind you. And so as part of this, we now had the approval, I think it was 2021. I remember it was in the middle of COVID. We were all doing Zoom meetings for these conferences. And I remember in the middle of giving a conference, the Twitter just started tweeting and off it went. And people all started texting to say, the first CAR T is here. And it wasn't just a year later that the second CAR T was here. And we'll talk about this a little bit in terms of what those CAR T cells are, what we've seen in terms of their successes, perhaps some of their challenges, and talk further about what's next, because we in science want to make it better. We have so much work to do to improve upon the successes we've had in order to continue those successes in terms of curing patients, but also not making it be a hard approach along the way. How can we decrease those toxicities? How can we improve quality of life at the same time? So this is how I like to wrap my brain around it, right? We talk a lot about targeted therapies in multiple myeloma, and that is exactly what CAR T has tried to exploit. So if you think of the myeloma cell, that purple cell that's there, the way I describe it to my patients is that there are tags on them. These are tags that identify them as multiple myeloma cells, but basically are wide open for the attack there. If we can say, aha, Dr. Kwok said melphalan is like drop bomb as chemo on anything in the way and kill bad guys and good guys. What if we had a better way that we could find a drug that looks particularly for the tag on the myeloma cells, just keeps walking past all the normal things and all the good guys there and really focuses itself on the myeloma cell as its main focus of attack. And there have been CD38 on the bottom there, which is the one that we have seen isatuximab and daratumumab really nicely target. CD19 is we'll talk about it a little bit later, but those three in the red boxes are the three targets that I think most specifically have been of interest in terms of how can we leverage these flags, these tags on them to say, we know this is the bad guy, go attack it that way. So the hope of a tag always is that it is only on myeloma cells, it's nowhere else as best as we can. We wanna know that if we are gonna fight it, we are gonna predominantly kill the myeloma cell and hope that we are not attacking or finding any innocent bystanders, otherwise that may have a little bit of that tag on it as well. And so these three targets have been identified as the best candidates. All right, so CAR T cell feels like this big kind of Pandora's box, and sometimes it is because it's very logistically challenging. And it requires, what I like to say is a team sport here. This is a team approach where you may be working with your local oncologist who has wonderful myeloma drugs that we've all enjoyed and have seen great successes, daratumumab, lenalidomide, pomalidomide, carfilzomib, good drugs that can be given by your local community oncologist. But there are some drugs that just need a little bit more expertise and a little bit more of an infrastructure, if you will, to support giving it. And CAR T cells are one of those. Bispecifics, for the meantime, are another class of drugs as well that are predominantly, at least for now, giving it our kind of academic centers. But it requires very close communication between the community oncologist and UCSD, as an example. So many of you out there in San Diego who have your community oncologist is on a constant text message with me where we are just consistently talking, how's he doing? How's she doing? Are we ready? Is it time to move CAR T? So if your ears are burning, we are talking about you behind your back pretty regularly. And what it takes is that if you are one of my patients, we can seamlessly do this, right? We can say, okay, you've had all these different drugs, it's time for the next one, let's go to CAR T cell therapy. But if you are a patient that's come to have a transplant with me, for example, you went back to your community oncologist, or you've been with your community oncologist for all these years and someone starts saying, it's CAR T time, it requires someone to think about it, right? It requires your community oncologist or you, as the empowered advocate for your own health that you are, to bring up the question and say, hey doc, is CAR T the right thing for me, right? So we talk about the brain to the vein time, which is who thinks of it and how long does it take to actually get those CAR T cells in you. So the most important part of this process is the person who thinks about CAR T being a good option for you, talks to the community oncologist and makes that referral into me, Dr. Goldsmith, Dr. Kwok, Dr. Chari, whoever it may be, so that we can start that process. Because this treatment is good, but the logistics are a little challenging at times. Because once the referral's been made, I wanna see you. I wanna talk to you about it. I wanna know if this is the right thing for you, the right time to do it based on other treatments that you've had, where we know that the benefits way outweigh the risks perhaps that are accompanied with it. Once we've decided that we want to proceed with it, we have to go through testing to make sure you are healthy and eligible and safe to go through the procedure. We have to then do the removal of those T cells. T cells, they're your immune system fighter cells, right? They're your fighter cells that are designed to look for the bad guys that are out there. But we're gonna teach those T cells to fight something more. They're designed to fight COVID and flu and pneumonia and all these things, but what if we took your immune system cells and taught them how to look for one of those tags on your myeloma cell? So by removing those T cells, which is not a surgery, patients ask me this, it is, if you've had a transplant, almost exactly the same thing. Instead of taking those stem cells out, we're taking out those T cells. It's like donating blood, right? It comes out of your bloodstream. We then take those T cells, we mail them off to a company who is going to do the re-engineering process for us. While that is happening, we are sitting by and anxiously waiting for those T cells to be ready to put back into you, which always takes longer than we want it to. During which time, we gotta keep your myeloma under control, right? If we can keep it under control, we know that your CAR T will have the most success. And so probably while you're waiting, you're gonna continue to get treatments because we wanna keep killing myeloma. We call that bridging therapy. Someday we get that phone call, they're ready, they ship them to us. Once they've shipped them to us, then we can start the process. This, up until this point, your doctor thought of it, your doctor referred you, your doctor, I was able to see you, for example. We went through all the testing process. We have now removed the CAR T cells. We have now engineered those CAR T cells. This is a several-month process. So I want you and your doctor to think about it pretty early on so we have that time to prepare. So I always say, if you are looking like you're starting to relapse first, second, third time, and you've not had a CAR T, it's time to start talking about it. Once those CAR T cells then get put into you, we go through the process at the academic center, get you through the recovery and recovery time, get you back to your home institution, your home oncologist, and kind of continue on with our partnership of taking care of you for the short and the long term, and we'll kind of review some of these things. So we talked about some of these barriers in terms of just knowledge, And you are doing that here today by being here, by learning about this. We need to get the word out because I think it's there, but I'm always surprised that I think there's still a gap in education that's out there that patients, doctors, people need to know that this is a wonderful treatment. This is something that has changed, we'd say, everything for myeloma. And I don't want to oversell it to some degree because I'm obviously a big proponent of it. They're certainly worth the conversation, and this is not the right thing for everybody. But it is the right thing for everybody to talk about. So let's talk about what it is and how we got there. We talked about that calendar a little bit in terms of how we got from the initial thought of it to the initial clinical trials to the drug approvals. And there were two specific clinical trials because there were kind of competing companies that were trying to race to the finish line to produce the first CAR T cell. Now, BCMA was the name of one of the tags I mentioned. BCMA is the tag that sits on the myeloma cell and is the one that is ripe for the killing. And so two different CAR T cells were initially developed in kind of the research studies to say, hey, how do these work? And just because we like to be difficult, we make these really, really long names, idacaptogene, vislucil, ciltacaptogene, autolucil. Let's call them ida-cel and cilta-cel. Carvykti and Abecma, those are the brand names. Both of these CAR Ts were designed to be studied in patients who had had lots of different myeloma therapy. Perhaps that myeloma had come back for any individual patients 3, 4, 6, 14 different times, and they had exhausted all of their usual suspects of treatments. And these were patients that had all your usual, if you know, lenalidomide, pomalidomide, daratumumab, for examples, and said, let's try this and see how it worked. And this was so important because we really had not a lot to offer these patients. And unfortunately, their prognosis was really less than anything we could have hoped for. Enter stage left, these CAR T cells. And what we saw was someone who, if I had just picked some drug off the shelf and written some prescription, it probably would have worked for a few months, which is fine. Suddenly, you have these CAR T cells coming in and they're working for, first it was 1 year, and then it was 2 years, and then it was 3 years. And so suddenly we're seeing significant improvements in progression-free survival. So it really changed everything. Where now these patients are, getting into remission, staying into remission, and living longer for having done a CAR T. What are we doing if we are not helping you live longer? So this was the initial 2 different trials of 2 different CAR Ts that were brought forward to the FDA, and the FDA thankfully gave us the seal of approval that we could start using these in the clinic without needing to be part of a clinical research trial. Well, heck, if it works that great, why wait, right? If you have had myeloma for many, many years and you've had all the treatments that are available, and instead of waiting for something, to happen years down the road, what if we now started saying, well, let's do it sooner. And that's what the next trial started to look at. They say, okay, fine. What if we only had patients who had their myeloma come back the first time, the second time, the third time, something earlier in your journey, right? This is a marathon. There's gonna be times when you are going for the big gun transplant and times when you're enjoying your maintenance. But there are times when we gotta kind of start climbing that hill again, and why wait for the biggest hill that's coming and just do it now? And so those same 2 BCMA-targeted CAR T cells that we waited and waited to use now are being studied in earlier time points in your journey. And these trials were slightly different. One of them looked at patients who'd had their myeloma already come back twice and was looking for the next newest and greatest. There was one of them that had it only when you had had it come back once and looking for the next treatment. But these are patients who maybe had had lenalidomide, maybe had had daratumumab, all the drugs Dr. Kwok just mentioned that are our go-tos when you're first diagnosed. These are patients then who underwent these clinical trial, which basically said, all right, I got this CAR T, we know it's good. We got all these other drugs that we've been using all this time, we know they're good. Which is better, right? Which is how we push this field forward to say, we got something good, we know this is at least probably as good, but maybe it's better, let's prove it. And so that's what these 2 trials did. They said, these patients who so graciously agreed to participate in this clinical trial, which is sometimes hard, were randomized, basically said, we don't get to choose. You're gonna get assigned to the CAR T arm, or you're gonna get assigned to the standard of care, which we think both are great options. We don't know for sure that one's better. You'll probably get the other one at some point anyways, but let's see how this goes. And when they compared them to typical combinations that I would ordinarily choose anyways, such as daratumumab, pomalidomide, dexamethasone, pomalidomide, bortezomib, dexamethasone, kind of our usual suspects of kind of combinations. They compared them and said, you get the CAR T, you get something else, let's see how it goes. And the CAR T won in both trials. They're different drugs. I don't want to sell them as being completely similar because in terms of different drugs, although they're attacking the same target, they do so slightly differently, which sometimes can result in slightly different toxicity. But for all intents and purposes, there are 2 CAR T cells that are out there, available, and both have proven to be better than whatever I could come up with off to the side on any given day. We are seeing, again, people having remissions that are longer relative to the standard of care treatments. We are probably going to see some overall survival benefit. We have to wait and see. So I figure it's worthwhile to think a little bit about what the process is like of CAR T. Now that we know that these are options available to, presumably all of you or many of you who have had their myeloma come back the first time, let's think a little bit about what CAR T is like and what it feels like to go through it. Because many of you have had a transplant, which is a very predictable process. I know exactly when you're going to feel terrible and when you're going to be cursing my name, and I know exactly when you're going to feel better and probably when you're going to go home. And I can tell you that at 2 months, you're going to be doing this, and at 3 months, you're going to be staring at me because you want to go out to eat and you want to go back to work. CAR T is wonderful because it is a one-and-done treatment. We call it one and done. We say you get your cells, and then all these years you've spent getting treatments every single month, going in to get your shot or your infusion or whatever it is. CAR T is you put those cells in, they go to the battle, they do their fight, and you're done, and you're off of treatment until it comes back someday. We hope that's years, right? Which is different from anything we've ever heard before. Myeloma has been, you will stay on your treatments and you will like it, but this is take it, get through the process, and enjoy time without treatment. So when we're thinking about how wonderful the one and done is, I think the other side of that coin is to say there's a lot that comes with the supportive care of it. So while you may not be getting treatments, you likely for some period of time will require ongoing FaceTime with me and our infusion center and our nurses and blood tests and all the things so that we can make sure your recovery from CAR T is smooth. Because it's less predictable than the transplant. And speaking of personalized medicine, we're going to see, one patient kind of do their CAR T cell, and perhaps after the first couple months, they're looking like, see you next month, doc, I'm good. There are other patients, however, though, that may need more supportive care because the unpredictability of it and their side effects profile may require patients to have more ongoing, careful, more frequent care. So the process. Once your CAR T cells are ready, the first thing we do is we are going to give you 3 days of chemo. Now, chemo doesn't have to be this bad, scary word that sounds like Melphalan, for example. Giving 3 days of 2 different chemotherapies. Some of you have heard of some of them, like cyclophosphamide. It's an oldie but a goodie we use. The intention of these chemotherapies are not necessarily to kill everything in its way like the Melphalan of a transplant is. These are designed to just scoot your immune system out of the way, to make room for the new immune system that's coming in. If it kills myeloma, awesome at the same time, but that is the intent of it, is to make room for these CAR T cells to kind of be ready to prime the pump for them to get in there and do their job. Once those chemotherapy are done, they are, you have a couple days off. Depending on the institution where you're doing it, some places have a little housing nearby. UCSD, we would love for you to come into the chateau for a little while, although we are in the process right now of making this an outpatient procedure. We are going to have patients come into the hospital, and those cells are going to be dripped right back into you like you're getting a blood transfusion from yourself. And then we wait. And the waiting game of the hospital is basically making sure that those CAR T cells are going and doing their job without causing too much trouble. Now, we are in the hospital monitoring you. You might wear the little, telemetry, the heart monitoring. We're going to check your blood pressure. We're going to check you for temperature, fevers. We're going to check you to make sure you're thinking well. What day is it? What time is it? Where are we? Who's the president? All the fun questions people like to ask. And the purpose of this is because when those T cells get in there and they're looking for the bad guy, once they find it, they attach themselves and go to work. They go to battle. They call their buddies in, and their buddies come to fight the good fight with them as well. And this, for all intents and purposes, can result in an allergic reaction, let's call it. An allergic reaction basically can look like small, medium, or large, is how I describe it to my patients. You can have a small little reaction where you have a fever. You can have a medium reaction where you're having a fever and maybe your heart's working a little harder, maybe your blood pressure's changing, or maybe you need a little oxygen, all because of the work that your T cells are doing. There is another form of a reaction that can happen, which is scary sometimes to feel, scary sometimes to watch your partner go through, which is that sometimes those T cells, wherever they're fighting, can find their way up here as well. And that can sometimes look like confusion, headache. Some people know that they want to speak, but they can't say the right words. Some people, it looks like they're having a stroke or a seizure. I want you to hear that these are all common and reversible. And that's why you're there under our care 24 hours a day, essentially, so that we can watch for these things to happen, and we have antidotes for them. We have an antidote that turns it off so that we can settle these things down and basically say, hey, CAR T cells, thanks for being here. Just chill out a little bit. It doesn't compromise their effectiveness. They're still able to do their job. We just want them to slow down a little bit. So in the hospital, if that's where you are, or at City of Hope, I think they have their lovely villages where they can have patients kind of come back and forth from their apartment, or if you live nearby, just come back and forth from home. We are watching for signs of those reactions. We know when that reaction happens. It's probably between the 7th day and the 14th day after the CAR T cells are put into your body. So it's predictable in that regard. Once you've gotten through that initial time point of the reaction possibility, then you get to go home. And people feel well when they go home, I would argue. It's not like a transplant where you've just been beat down sometimes and we're just building you back up. A lot of times people, they're certainly fatigued. They may have some residual nausea. But practically, for all intents and purposes, you go home, you're independent. You are eating, feeding, dressing yourselves. You are doing okay. Then begins the supportive care for later toxicity or later side effects, because those CAR T cells are still in there. They're still doing their job. They get in there, they kill quick. We'll see, which we love, is your light chains, whatever they started out, plummet. We're gonna watch your M spike on every check. Thereafter, really continue to fall. The response rates for these CAR T cells are very high. I mean, it's 90+% of patients are getting the CAR T cells to work, right? And so once they have gotten in there, you're home, you're feeling better, we'll have you set up where you're coming in every so often so we can check your blood tests. And what matters here is that your blood tests, like a transplant, drop down, and for some people, bounce right back up. For some people, they drop down, they take a little extra time to bounce back up. Some people drop down, bounce up, and come back down again. So it's the unpredictability of a CAR T that requires such kind of intensive follow-up so we can figure out how this process will go for you. Your immune system is quite weakened from this. I just said I got rid of your immune system to bring in this brand new shiny Cadillac, but it has one road it's going towards, right? It has compromised your main immune system and given you an immune system that knows how to fight myeloma. And so while we love that, we need to protect the rest of you. And so there's lots of antibiotics and antivirus medicines and infusions of IVIG, which are like donor immune system cells that are given to you to help boost your immune system while we're waiting for your own immune system to recover. So we have very specific parameters of what we're looking for, and know that some of these side effects that can occur can happen kind of at very more or less well-known time points. Here, the cytokine release syndrome was the first kind of reaction I mentioned, and all the different ways that it can manifest and why we have you in the hospital or have you kind of under our acute watch so that we could intervene with that antidote as soon as it were to happen. The neurotoxicity, as I mentioned, is something that we know can happen, and it can happen in a short course. You can have one without the other. You can have both, oftentimes one followed by another. But these are a couple of the different side effects I mentioned. There can be small, medium, and large forms of the neurotoxicity as well, where patients may just have a headache. But as mentioned, some of these more significant, reversible, temporary side effects that can happen in this early time point. And we have different ways that we do that. Sometimes we need patients to receive those antidotes. A lot of times if patients have fevers, we're worried about infections because that can happen kind of all in the midst of this as well. So we're very thoughtful about making sure we're covering all of our bases while taking care of you, taking care of the CAR T cells and their reactions, taking care of the immune system weakness and protecting you from infections along the way. Now, once we've gotten you through the main event, comes kind of what happens in the later point. We are enjoying this time off of all of your treatment, but just because you're off therapy doesn't mean you're done with me yet. You're gonna still need to come in and keep getting your blood tests. We're gonna keep giving you whatever we need to until your immune system boosts back up again. As mentioned, some people need blood transfusions, platelet transfusions to keep their their blood levels in safe levels. Some people need different medicines to help boost that, to help it happen faster. But what we know is that your immune system has been compromised, and that time that it takes for it to recover can be months. Where if you go back to your local oncologist after having been with me at UCSD, I'm gonna send a checklist that says you need to do this and you need to do this so that we can make sure we're protecting you for the next 6, 9, sometimes 12 months as your immune system continues to recover. Now, what does that practically mean? About common sense. I want you in those first 3 months to be very careful. I want you to be very aware of who you're around and what you're doing and where you're going, and probably will, tell you to just stay put for a little while. From that 3 to 6 month range is when we start lengthening a leash a little bit and say, okay, yeah, you can get out. People who know and love you and know what you've been through and want to protect you are gonna know the rules. But perhaps it's not time to go to a concert, in the mosh pit around lots of people, But next, as you continue these months go by, we're gonna start lengthening your leash more and more because your immune system is gonna start growing back again. But some of these delayed toxicities are critical to for you, your local oncologist, me, as you check back in with me to know about. Now, a lot of patients will walk in and say, I want CAR T, and we start talking about it because the successes are very well known, but what is not as much talked about are some of the later term side effects. And again, this is a big conversation of weighing your risks and your benefits, and there are a whole heck of a lot of benefits to this. But there are risks that are involved that have to be thought about and talked about because we need to make sure that they're acceptable toxicity for every individual patient. So what are the later effects of CAR T cell? Well, this is a lot of therapy. Fatigue is common. Patients can take some time to develop their energy back. There are different strategies of exercise and yoga and meditation, Pilates, massage therapy, things that over time can help improve that, where I think tincture of time is probably the most important. We think the neurotoxicity component is confined to a very specific time point but we will say, we think it's 7 to 14 days what's gonna happen, but because, at least for now, a lot of people are hoping to fight this, is that we worry that there could be something that happens in the weeks to follow. So the FDA from the get-go said, no driving for 8 weeks after your CAR T. So caregivers, we need you to be in charge of being at the wheel, in addition to your pharmacy, in addition to your other roles that you play for this. Financial toxicity is real. There are a lot of support systems that are out there for copay assistance, for housing assistance, for transportation assistance. The companies that make these CAR T cells want you to get this, so they're gonna make it easy for you. And we use as much as we can of that to help people with whatever financial assistance they may need. Can be distressing for patients and caregivers just to go through this process, which we sell as a short process, and sometimes, whether we like it or not, is a little longer. And it's a matter of making sure we're engaging you with your support system that we have to offer at the hospitals, social workers, chaplains, whatever that may be, clinical-based psychologists, and you and your support system with your friends and family surrounding you. Secondary malignancies is a kind of a thing that's come up, and it's hard, I think, to parse out what is causing the great irony of cancer treatments causing other cancers. There was some correlation to say that CAR T could perhaps be associated with getting second cancers, but a lot of our patients have had so many other therapies that cause cancers. I'm not sure that the CAR T is definitely the thing that is the absolute culprit here, but it's on our radar that people are paying attention to. I want to talk about that. I didn't have a slide here, but I think some of the buzz that's coming out a little bit more is some of these kind of changes that we're seeing in neurologic toxicity as well. And I want to preface this by saying it is not common. It is not common to have this thing, but it is a real thing that we have to be aware of. So about 10 to 15% of people in the weeks after their CAR T cell can develop, and we do not understand why this is happening, but the CAR T cells are misbehaving somewhere up here. And about 10 to 15% of patients can develop what's called a Bell's palsy. Maybe you've heard of it. It is a paralysis of the face. It's the nerves that send from the brain to your face that tell you how to smile and move your mouth and move your face. And 10 to 15% of patients can have this reversible, temporary paralysis of a face that requires some time to recover, but something is happening with the CAR T cells that are affecting those nerves. Other neurologic toxicities that can be seen, and this is very uncommon, but it's something we're seeing happen about 0.5 to 1% of the time in the clinical trials, is the development of something that looks like Parkinson's. So Parkinson's, people are familiar with. People maybe are not as expressive with their face. Maybe they're not walking as well and more shuffling gait. Maybe their coordination is decreased. Something is happening here. There's a signal. We don't exactly understand, but the good news is that it is not common, but it is not zero. And I think the next generation of CAR T cells are gonna have all of these hopefully be at zero. But it is a side effect you have to know and be aware of. Where 99.5% of patients are not having this, we have to be prepared at that possibility. That is unfortunately something we have not yet figured out how to cure, should it occur, but we're continuing to research this, continuing to try to understand this. So again, weighing benefits and risks and understanding what it is that we're putting you through to truly, really try to enjoy a very deep and durable remission while weighing in the perhaps low risk, but some of these significant side effects that can happen. In my final couple of minutes, I wanted to kind of give you a sneak peek into the future of what's coming here, because I've talked about all the great things that are happening with CAR Ts and some of these not so great components of it. And as I started this whole talk off was to say, we can always do better. We can always make our products more successful and more safe. And this one was presented at ASH just this year, which is the next coming kind of BCMA targeting CAR T cell that looks pretty darn good. It is looking similar in terms of its successes to cilta-cel, in terms of how deep of a response and how durable you get. And so far, not a lot of those other neurologic toxicities that we're seeing. So stay tuned, keep this anito-cel on your radar. Just a plug for it at UCSD. We have a clinical trial of that is randomizing, again, patients to get anito-cel or the standard of care, so we can see if this is the kind of next newest kid on the block that's gonna do better than the successes we've already had. Now, in the beginning, I also showed all those different targets, and we've talked a lot about BCMA here. There are other targets that I think we can attack, and Arlo-cel is another one of these CAR Ts that says, okay, fine, we looked at BCMA as one of those tags. GPRC5D alphabet soup is another target that we can attack. And so there's a new CAR T that's out there that is trying to attack a different target. With different targets, sometimes they can have them be found on other parts of normal parts of your body, comes perhaps different toxicities. So we're excited about new CAR Ts and new targets and how they may work, and continuing to learn about how new targets may be ripe for the killing for myeloma and what side effects may come with it. So far, really exciting information that's coming out that shows perhaps you can kill BCMA first, and then you can kill GPR next, and maybe we can just one by one attack all these different targets that are on the myeloma cell and have really good successes with it. But heck, if you're gonna say one by one, what if we just did two at the same time, right? What if we had a CAR T cell that had two magnets on it, two different radar systems, and attacked two of the targets at the same time? That sounds like it would perhaps be pretty successful in attacking the bad guy, kind of, I always say, with a lead pipe and a revolver and a candlestick. If you could attack it Clue style, why not? And so this is one of the next kind of CAR Ts that's coming ahead of us here, looking at how we can combine target attacking to kill more successfully. And the last one I didn't put a slide in, I want to say, is just a hint about it, also have at UCSD, is one of the worries is that your T cells have been so beat up all this time. I have hammered it with Dex and Dara and all these drugs for so long, and now I'm saying, hey, T cells, get to work. Let's get doing this. A lot of patients' T cells are just not as strong as they once were, and why patients are looking at, and why studies are looking to say, well, it worked, CAR Ts worked then. CAR Ts are, we're looking at it now in earlier relapse. Heck, let's look at CAR Ts when patients are first diagnosed. But maybe one of the other things we should think about is donor CAR T cells. What if you had a healthy donor whose T cells are just prime for the killing, and we can train them and teach them? Perhaps we can use donor T cells to effectively kill your myeloma as well. So sneak peeks of little exciting things that are come. What is more personalized than this, right? CAR T cells, your own immune system killing your own cancer. There are challenges and unique toxicities that come with it, some that I've touched on here, and a lot of logistical challenges as well, just trying to figure out exactly how to organize it with you and your support system and your local oncologist and being at UCSD. But also, as Dr. Kwok mentioned in the beginning, there are so many drugs that are out there now. I will say I do this 100% of my every single day. Every breath I take is myeloma, and I still don't know sometimes what is the right approach, because we're learning. But one of the questions that comes up is, with all these drugs, should we do it in this order? Should we put the cart before the proverbial horse? Should we figure out, with all these drugs, how can we leverage them to each individually be successful without compromising your next therapy? So this is the next questions that come up, because there are a lot of treatments out there, so I really want to make sure you're thoughtful about choosing the right one at the right time, and that's where I think us myeloma doctors can help support you and your local oncologist. So lots of excitement. CAR T is here to stay. We have seen great successes with it that have improved the lives of people, have saved lives for patients with myeloma. We have work to do. We have work to do to figure out how to make these safe and effective, and lots of questions that still remain, but I'll tell you, the future's pretty bright.